Thanks, Ed. Janine, Ken, get your thinking hats on. Some of this, I wanted to take a few minutes today. I was in a meeting with Daryl Ruby earlier this week or last week, whenever it was, and we came to the realization that we need to dedicate some time sharing this. And I went intentionally low tech with this presentation, and I hope that's okay with everyone. For those that are attending my GoToMeeting, I'm holding up a binder of the 2017 through 2022 Healthcare Preparedness and Response Capability. This is a couple hundred, or not that, it's probably 100 pages of guidance that is used to help healthcare coalitions and communities meet objectives that ASPR has been funding. And I call on these two individuals over here that attended a conference with me in December of 2016. It was put on in order to share best practices, lessons learned, and a little bit about the work that we all do with these coalitions, trying to create that coordinated response to emergencies within the healthcare and public health and medical sector. So the conference was incredibly illuminating, and it a shift from previous years. It focused heavily on what ASPR's thinking and what's happening within CMS, and where's this all going and where it's coming from. And I thought I'd just take a few minutes to kind of frame the world according to Travis and how I've heard those things. And I'm asking some of the other individuals who attended to maybe think about what they might add to my thoughts on this. But I'm the last person that should give a history of hospital preparedness program as it's currently, or was called, now the healthcare preparedness program. And I should have slides for this, but where this all comes from is at the federal level. Back in 2001, we had 9/11, right? And we had a major anthrax and bioterrorism threat. And the response to that within the healthcare sector was woefully inadequate nationally. I mean, we were not ready to deal with the threats that were there. And our federal government thought it was a worthwhile investment to spend a fair amount of energy and financial resources in making sure we improve our readiness to respond to disasters. And the National Hospital Bioterrorism Preparedness Program was founded. It went through an evolution there, and Ed, jump in if I'm getting any of this history wrong. But that initial effort was just that, an initial effort, and it evolved as the nation faced additional threats over time. In Katrina, we learned some really important lessons in 2005 that helped us inform the next evolution of this work and formed the Hospital Preparedness Program as we've been operating under it today. That also provided some of the guidance that allowed healthcare coalitions to come in, share resources, share expertise, and try and create better community outcomes as an organization. So all that to say that the funding that I operate under, that Elena, Mira, and Ed, and some of the others that work on these projects, it's a federal program under the Health and Human Services Department that has a organization called the Assistant Secretary of Preparedness and Response within it that is entirely focused on administering community-based public health and medical response. So the program at a federal level is gone through a number of changes, like I mentioned, and that initial investment was one of the first times that the federal government said, we're gonna spend money to help what are nonprofit and for-profit healthcare organizations, make sure they have continuity of operations planning in place, make sure they have a community response. And we're just finishing a 5-year set of capabilities and cooperative agreements. And so coinciding with the CMS rule, and the reason we're talking about this today is this is a momentary shift in the history of where we've been and where we're going. We're going from a time period where the federal government was investing in community-based healthcare planning, right? They were spending money on decon trailers, on equipment. If we need communication systems, the money was there, right? If we needed it within healthcare or public health, we could turn to the government and buy equipment to be able to get there. But the reason this is a pretty important shift in these capabilities, which I'll talk about specifically in a minute, kind of what we're seeing within this document that guides some of our work. But we're seeing this as an important point to the next 10 years, because what got us to here was learning from these lessons and learning where we can resources and what's important to it, what can actually change the outcome of response. But coinciding with the CMS rules, it's really the line in the sand for the federal government to go from we are subsidizing continuity of operations planning, we're spending money in the federal government, to how do we create enough value through a seed program, kind of what we're working under right now with these coalitions, to the point where healthcare is starting to own it and really move forward with it on their own, and thus the CMS rule. These are expectations being set that healthcare will now build into its business practices enough to be able to create some of these community responses in order to save lives during a disaster and scarce resource shortages. So any questions on that kind of like big picture thing? Because I think in 10 years from now, one of the things that I heard very clearly during the December conference was 10 years from now, the hospital preparedness program that became the healthcare preparedness program that will now be called the healthcare preparedness and response program. Whatever evolution it takes, it won't look like what it does today in 10 years. It might not be here in 10 years. And I think that's an important realization for those that are involved in community-based healthcare planning for quite a while, to realize that our work is critically important, but it's also something that's not going to happen in the form that it does today. So we've got to continue to evolve. And I'm really glad to say that our healthcare coalition here in Region 9 has spent a lot of time focused on strategic planning. 2014 was our major initiative there. In the last 2 years, we've made efforts to try and continue that work, but it hasn't been as robust as it needs to be. It's definitely one of the areas of focus for thinking about how do we sustain our work? How do we sustain this organization coming together to make sure that it's responsible? So to share a little bit about this complementary document, this document takes what was a number of capabilities that were mirrored in the public health capabilities document and shortens it down to 4 areas of work that we really need to focus on. One is making sure that we have the foundations in place to create a coordinated response within the community. That our healthcare coalition is sustainable, our healthcare coalition is viable, has the right people at the table, public health, emergency management, and healthcare of all varieties and disciplines, and that we have the right risks and hazards in front of us when we're doing our responses. The next major area of focus for us is making sure that we're able to coordinate our response with our ESF8 lead agencies, public health. So making sure that when in Washington State there is a response, healthcare knows how to integrate with them and work with emergency management successfully through a strong incident command structure. The third capability is continuity of operations planning. That's making sure that everyone in this room and all of your associated organizations have the ability to stay in business when disaster strikes, that you have the right staff, the right resources, you have the ability to keep your services available to your clients. And finally, medical surge. What do we do when there are scarce resources and our systems are overwhelmed, and how do we start to manage an influx of patients beyond normal capabilities? So there's 4 areas of focus, and that's a big departure from what these capabilities documents were for the previous 5 years, where there was a lot more detail to them, and there's a lot of details of these when you start reading into these. These are kind of super bullets down into the more detail. But it's a really clear area of focus about what our coalition should be looking at and how that integrates with our governmental organization framework and with our healthcare. Sorry about the mic drop. Some of you have noticed this on GoToMeeting or in the room. Side comment here, but we have been working actively with Endurance Training Center to resolve this. It's an ongoing process, and I apologize. Any questions about that? I wanted to just throw this out here and share a little bit about what we're looking at organizationally with these capabilities. And the link is available. People can read through it, but rather than scroll through a 100-page PDF, I thought I'd just give a high-level overview and just share that kind of some of that background about where we're at today is not where we were 10 years ago, and it's not where we're going to be in 10 years. Yeah, do you want the mic? Summary for GoToMeeting of Janine Wilson's comments. The program and the new capabilities have expanded the focus beyond hospitals, public health and emergency management to all aspects of healthcare, including the 17 CMS provider types. Ken, any comments from your perspective? Great. I'm going to jump in and introduce our next segment, and I think, Janine, you nailed it. One of the things that I love about this audience right here, and it really gets to what coalitions are about, is sharing expertise. And when we started looking at how do we start to work through these elements with the different provider types, some of our organizations in our region have been doing this for quite a long time, whether it's for Joint Commission accreditation or other accreditation standards. And so we've asked Daryl Ruby, I think, are you first in the agenda or second? Daryl Ruby is going to come up and share some of his background and experience when it comes to identification of risk. One of the first elements of the CMS emergency management program is to make sure that you're focusing your ability to respond on the right risk. And so having a THIRA, having a hazard vulnerability assessment is critical. And so we start to look at some of, first with Daryl at the regional level, as the regional resources that are available in risk assessment. And then Deaconess Hospital, Dean Davis will share next